Wow, what a sight. You don't get to see it from the back there, but this is beautiful. I'm going to tell you some stories today and sort of take you through one right now. In December of 1881, Caroline Kennard, a prominent leader in women's movement with an interest in science, she actually wrote to Charles Darwin. And what she did was that she was trying to inquire about his views on the scientific principles of the inferiority of women, which were laid out in his famous 1859 book on the origin of species. She expressed surprise that a scientist as eminent as Darwin could really believe that women were biologically inferior to men and presumed that she'd misunderstood. Darwin wrote back to Caroline, assuring her that his views were not a misunderstanding. Women are inferior, he wrote, adding that they were better off not aspiring to anything outside of the house and thus did not evolve. He further wrote that it was only a stroke of biological luck that stopped women from being even more inferior to men than they already were. A stroke of biological luck. For hundreds of years, this was the common understanding that women were inferior to men. They were the inferior sex. They were considered the weaker sex, unable to do math or science, and often considered subservient. Charles Darwin was sure of it, and for decades, scientists, most of them men, claimed to find evidence that supported the inferiority of women. But Darwin got it wrong. How did he get it so wrong? He was a successful, meticulous scientist, but he didn't apply scientific principles to a study of all humans, but only to half of the humans. A theory that leaves out half the human species is really unbalanced. When I read this story in Angela Saini's book, Inferior, I was indignant. I was indignant about Darwin's response, his resoundingly incorrect argument that men are superior to women. But as I reflected, I realized that it's hard to tease out the human being from the scientist. And we've seen repeatedly that both the sex of the scientist and the context of current day society and culture greatly influences how scientists frame the study questions and also how they interpret the findings. Darwin wrote his book just shy of 150 years ago. Today, as women, we are still grappling with this legacy. When I first began my medical training, I was far from being the only female student in the classroom. Yet our professors, residents, department heads were almost all exclusively men. These men had many years of experience in the medical field. They were successful teachers, clinicians. They led leading institutions and devoted their entire careers to helping others. While it may be an accurate reflection of what medical school looked like, it wasn't an accurate description of what the world looked like. In 1991, when I graduated from medical school, I didn't fully understand the impact of not having women as teachers, scientists, or as leaders of medicine. What we now know is that the lack of women, diverse persons in medicine, research, and leadership has resulted in significant downstream toxic effects. Women were actually excluded from clinical trials until 1993, when legislation was introduced that required women to be included in the US. Only since the 1990s were women considered worthy of inclusion. Until then, it was pervasive throughout science, throughout clinical teaching, that the male body was the norm, regardless of age. I don't know about you all, but I don't feel like a 75-kilogram male. Without women in clinical trials, we can't account for differences in biology by age and sex, which could affect long COVID, for example, differences in body size where doses need to be adjusted, and adverse effects on drugs, which actually occur much more often in women. We need to continue to advocate to ensure that women are included. We need to educate researchers, medical educators, and clinicians to ensure that women aren't left behind. During my residency training, I was sent to see a patient with my attending physician, a famous cardiologist. He explained to the patient that her heart wasn't pumping well, and he used a car analogy about pistons. Some of you might get that. I told him jokingly that his analogy was actually sexist. I jokingly said that to him. He laughed and he reassured me. He said, being from Michigan, she knew about cars. She'll understand it. Not surprisingly, I had to return to my patient and explain to her that, in fact, her heart was not pumping well because she didn't understand the piston story. And then I explained what was needed and what we needed to test. She was surprised to find out that actually women can have heart disease. And this experience really showed me a number of things. It showed me firsthand what the downstream effects are of the effects of gender disparity in medicine. And gender disparity affects everything, from how we communicate to patients and the narratives that we use. My attending never asked the patient if she understood, he just assumed. He also taught me about the biases in the medical system, from diagnosis to tests to treatments, and all the things that we can modify in our care for patients, but that aren't well studied. When I needed to make medical decisions for my patient, it was impossible to find the data that supported a well-founded approach. I was one of 4 residents. 3 were men and 1 male staff. I was the only woman. This was very common during my training. And I was sent to figure out the differences between women and men in heart disease and report back to the team of men. So this story happens to a lot of women in many contexts, many people probably in this room. I was most likely a little irritated, so I took on the challenge to know more, and I wanted to beat the other residents. But what I recognized was what I thought was a gender disparity, I've now recognized as thinly veiled sexist system that actively contributes to poorer quality of life and higher mortality rates for women. And this myth is perpetuated even in 2023, as most recently asked by a reporter if women get heart disease. When I began studying medicine, there were few clinicians and researchers studying women's health, and clearly not enough to be able to rapidly transform medical care and ensure equitable care for women. Remember what I said before, a theory that leaves out half the species is unbalanced. And we saw how Darwin's gender actually impacted and influenced what he studied and how he interpreted those findings. And this is true for an individual patient, at a hospital, or in a healthcare system. The people who do the work are a direct reflection of the type of work that is being done. And so how can we change things? How can we make that different? Women make up 51% of the population and represent over half of the health science graduates. Yet, as you can see in these figures, only 28% of the country's scientists are women, and even fewer are women of color. More than 65% of the hospital executives and deans of university are men, as reported by the Globe and Mail. And we can change if we have more women in healthcare leadership, science, and medical education. We need to change medicine. And we've seen focused efforts on hiring have changed the landscape, as you can see in this phenomenal room. We've seen the direct, tangible, and impactful results of onboarding more women. Because whether you realize it or not, it does matter who does the work. Marian Wright Edelman actually said, a civil rights activist in the US said, "You can't be what you can't see." In Canada, a 2022 report by Ill-Equipped sparked national outrage when it was revealed that there were actually more CEOs named Michael and Mark than there are women CEOs in all of Canada. I apologize if there was anybody called Michael and Mark in the audience. When Lisa LaFlamme was fired for looking her age, it prompted international furor. And in fact, even CNN correspondents, Don Lemon and others, right, discussing the gendered politics of hair color. Wendy's Canada actually drained the hair color from the red logo. But when it comes to representation in medicine, we don't always match that same fury. Like Darwin, people asking questions, interpreting the findings are vital if we want to address women's health. Representation matters. It brings diversity of thought and experience to research, ensuring that everyone's point of view is captured to create a truly equitable healthcare. It wasn't until 1997, only 26 years ago, that Congress wrote the National Institute of Health Inclusion Policy into federal law, forcing researchers to include women in all research studies. And only in 2000 did the Canadian Institute of Health actually form the Institute of Gender and Health. Now, it's commonly acknowledged that it takes 17 years for research to trickle down to clinical care. So arguably, we have only had 10 years with women included in clinical trials. So many treatments we currently prescribe likely did never get tested in women. And only this year has the FDA started requiring ethnically diverse populations in order to understand outcomes. So from the 1990s to now, we've only had 30 years to address equitable healthcare. So what have we missed? How many women have actually fallen through the cracks of our healthcare system? And who is studying diseases more common in women? Arthritis, inflammation, heart disease, BRCA2 mutations. For years, women suffering from heart attacks were sent home from emergency rooms in Canada because they didn't report the typical chest pain seen in men. Medical researchers had reported on this bias, but practitioners and women were not aware of the science that most common symptoms of heart disease in women are nausea, intense fatigue, and shortness of breath. Also, that diagnostic tests for heart disease perform differently in women than in men. To this day, a woman dies of heart disease every 22 minutes in Canada. Every 22 minutes in Canada. Most are not aware that heart disease is actually the leading cause of premature death in Canada. Most of you may not be aware that you probably carry at least one risk factor for heart disease. Most people don't recognize that many women are underdiagnosed, undertreated, and further, this cardiac clinical care is often undersupported and under-researched. The implication for this chronic gap in care is quite literally a matter of life and death. Disparities still exist, and we need to continue to challenge the system. It became glaringly evident during the pandemic that there were persistent disparities deeply ingrained in the system. And the truth is, people are being left out both systemically and intentionally. Women, people of color, seniors, those who are at any social, cultural, or socioeconomic disadvantage. In terms of equitable healthcare, we're not meeting the needs of our entire population, and those that have been systemically and structurally marginalized. In Canada, physicians use an equation to estimate their patients' risk for kidney disease. This equation uses blood levels of creatinine to detect kidney function. A race correction was created to actually solve for the fact that creatinine estimates were widely believed to be inaccurate for Black people. And the decision to use the race adjustment was left to the judgment of clinicians. The race correction actually falsely increased results by up to 10%, leading to a delay in diagnosis. Patients weren't referred for kidney care, not given potential life-saving therapy, or not being offered a kidney transplant. In Canada, Black people have a higher incidence of chronic kidney disease, have more rapid kidney disease, more rapid progression, referred later for kidney care, and are less likely to actually receive home-based dialysis therapy or kidney transplant. Report after report was written about the race equation, demanding that change be made to ensure equitable reporting. This kind of action is critical to ensure that we correct the biases that occur in medical care. For women, all diverse persons. And at Women's, our mission is to actually spearhead research that impacts not only our patients, but the healthcare system. We were built in 1883 to provide care for those that did not have access to care. We were able to focus on inequity in access and address healthcare gaps. We know that addressing and embracing complexities, as opposed to neglecting them, are the markers of a healthier future. And so we actually have a vision to change practice, to change policy, to change lives. The Women's College Research and Innovation Institute is currently leading the charge in closing research gaps for women and marginalized communities. We are at the beginning of a future-forward approach that embraces all women, all persons regardless of gender and ethnicity, that will understand that each patient who walks through the door of the clinic will be treated as a whole person, as a unique social and cultural background and unique physiology. We can actually build care that understands our diversity and meets the needs of women everywhere. When I joined as Vice President of Academics at Women's in September of 2021, the work towards building a healthier system was already well underway. I've been in my career for almost 2 decades. Don't tell anybody. At several prominent institutions. And at each institution, I've had to advocate for women, for providing training programs that actually provided better training for women and accommodated women residents, for more women in nephrology, for more women in leadership, and for more women in diversity in science. I've often been the only woman in the room. I'm finally working at a place where I don't need to explain what equity means. I can just get on with it. I can implement programs to enhance equity in science and healthcare, instead of talking about why women and diverse persons need to be in the room where it happens. We think of Women's College Hospital as a living lab to understand how to continuously reinvent and reimagine how healthcare can be delivered, and better integrate science into clinical care and translate out to better outcomes. This is a learning health system. an integrated approach to utilizing data, new scientific discoveries, improving outcomes, and understanding barriers for women and those from structurally marginalized communities. If we need to use technology and data to help advance for better care, safely and effectively, we need to evolve our approach to healthcare and the rapid integration of research into clinical care. It shouldn't take 17 years. The pandemic showed us it can be done in 1 year when the science is ready. We also want to engage patients and communities. You heard just before how important it is to think about how to advance care, how to improve outcomes and quality of life. While we can't solve everything, it's a crucial first step. It puts our patients at the center of the constant feedback loop, allows us to lead in groundbreaking research that impacts patients and the healthcare system, and importantly, allows us a glimpse into the future where care for women and diverse persons looks informed and equitable. If we help women actually have improved health, you help families and communities. You help everyone. A future where researchers ask important questions for women and findings are implemented quickly, and the education is provided about changes to healthcare. This is how women should be taken care of. A future that is forward-thinking and driven, one where no woman, anywhere, feels left behind. It is clear that data on ethnicity, gender, and sex are often lacking, but necessary and important to ensure the delivery of equitable healthcare in Canada. As leaders in a women-focused research at Women's College Hospital, our scientists are constantly sharing and mobilizing knowledge about health conditions that have important implications for women throughout their lifespan. We study health during reproductive years, including genetic testing for BRCA1 and 2, to menopause and aging, to addressing social issues, mental health, and chronic diseases, and using digital health across the healthcare system to improve care. Real-time data and science and education are really the fuel behind a healthcare system that understands and thinks differently, one that can really think about sex and gender and ethnicity with intent. It's been 10 minutes since I began talking to you today. I told you that every 22 minutes, a woman in Canada dies of heart disease. In 12 more minutes, another woman will die of unrecognized heart disease in Canada. In 12 more minutes. It doesn't have to be this way. It is not okay to have a healthcare system that does not provide the best care for women or diverse communities. We shouldn't be satisfied with only marginally better. We should demand that science, research, and health providers ensure equitable care for women and diverse communities. And as I look around the room today, and I see all you amazing women and all the allies over here, it has never rung truer to me that Darwin got it wrong. We have never been inferior. We have changed the way boardrooms, banks, businesses, consultancies, law firms, the mayor's office, hospitals look, think, and act. And we can change medicine too. I'm standing here today with the hope that, and the belief that we will no longer have to pass down my frustration, our frustration, or indignation to the next generation, to our daughters, to our students, to our colleagues. And we can ensure that for the rest of the time that women conduct cutting-edge science, implement research findings into practice, and to ensure the best healthcare for everyone. Darwin got it wrong. 150 years ago, he got it wrong. But in 2023, we can make it right. Thank you.